delighted to present today Ewan Phillips, the CEO of Deltex Medical, who will now tell you about an encouraging first half to the year concluded and share his thoughts about the prospects for the group going forward.
Hello, thanks very much. I've got a slide set here. Some of this has been available on our website for the last few days, but I've also put a few slides in at the beginning, which for those who are not familiar with the story, I think set some of the background. So I'll run through those fairly quickly first. Any questions, do just email them in and we can pick them up as we go, or after I've been through this. So first thing here is fluids, and here we're talking about intravascular fluids given by doctors, primarily anaesthetists, either in intensive care, but most of the time we'll be talking about surgery here, to keep blood flow moving, to keep blood going around the body, getting oxygen to the tissues. Now, fluid practice varies widely. So this first slide here is really looking at that. A big study that we were involved with for 2 or 3 years through an outfit called Premier. Looked at over about 500 US hospitals over about a 2 or 3 year period and well over 500,000 patients. And what they found was extremely wide variation in fluid given for the same procedure. So if you look at the graphic there, you've got, when you get into sort of the minimum amounts of fluid per hospital, this is taking the same sort of case, and some hospitals give as little as 1 to 2 litres of fluid across, the 5, 6, 7 days of sort of that perioperative care. Whereas there are other hospitals for the same patient, effectively, for the same procedure, are giving 22, 23 litres of fluid. So that's an enormous difference in a vascular system that's only 5 litres size, in multiples of different fluid. Of course, these are then associated very strongly with differences in outcome. So if you have too little or too much fluid, you have more complications, stay in hospital longer, it costs more. So there is a big problem there which needs to be addressed by the doctors, by hospitals, by quality improvement, and of course by industry who can provide the tools to help. Further, by way of background, having a complication after surgery is bad news. Very bad news. And so this is another big data type of study from a few years ago, about 10 years ago, by a guy called Curry and his colleagues, and they looked in at the VA system, the Veterans Administration System in the States, which is unique in that it has complete healthcare records covering both primary healthcare back in the community and anything that happens in hospital. So they were able to follow up as to what was going on to patients after surgery. And what they found is if you had a complication, one of about 22 types of complication after surgery, be it for a very major procedure, what they call AAA, an abdominal aortic aneurysm, and surgery on that complication reduced life expectancy by just over 7 years. But they also found the same thing for relatively low risk procedures, laparoscopic cholecystectomies, not a huge trauma if it goes well, but if you get a complication it knocks over 8 years off your life. And in the round they found across all types of major surgery it was between 7 and 10 years reduction in life expectancy because of a complication. Now, for doctors, quite often that comes as a surprise because they're focused on the event, not what happens long term after that. I think if we all know stories. You hear of so-and-so who died in their 50s or early 60s, and you go, that's young, but of course they had that big accident or whatever in their 20s, 30s. So we kind of understand that, and having major surgery and then a complication makes it into a big accident, and it does reduce life expectancy. So this is within 30 days post-operatively. Any one of 22 types of complications was bad for post-operative survival, not just in the short term, but also in the long term. Cutting the same data in a different way, the type of complication does have a bit of a difference, but all complications are bad. So pulmonary complications, clearly those are nasty. They take over 10 years off the average person to get one's life. Wound complications, which can be both superficial and deep, taking about 5 years reduction in life expectancy. So what does this sort of do with us? We use ultrasound and the Doppler effect, and you can see from the image there, we put a probe through the mouth or nose down the esophagus. That's the food pipe that goes from the mouth down to the stomach. Put it down there, point it backwards, and we're looking at the aorta, and we bounce a low frequency ultrasound signal off the red blood cells as they travel down there. On the right you can see a diagram, and unfortunately this one isn't animated for this purpose, but what we do is we do this about 180 times per heartbeat. So we plot a very accurate measurement of the speed of whatever's going past the tip of the probe, the red blood cells going past the tip of the probe at any given moment. And then we do another one, and another one, and another one, and another one. So that builds up this image. So on the On the left going up, you've got velocity, and on the bottom, you've got time. It builds this image up. Represents the blood. It's a good image of the blood coming past the past the probe. And then what the computer does is look at the measurements of that. It measures the area under the curve. It's very, very accurate. So this is telling you what's going on right in the center of the body in real time with a very, very high degree of accuracy. The sort of data now which you can just about get if you go and put someone into a sophisticated 4D MRI machine. If you've got an hour free to go and do that and do all things like that, you'll get similar quality data to this, or we can do it set up in seconds very, very reliably. And use it to do one thing. So we measure that blood flow directly. It means the technology is so precise it sees very small changes, so the doctors can fine-tune the circulation, fine-tune that, keep the oxygen going to the tissues. That means they can actually get on there not just to monitor but also to manage, do things which make the blood flow optimal. Now doing that, keep the oxygen going to the tissues. If you can do that, the tissues suffer fewer complications and people do an awful lot better. So overall, use of our kit over many years in lots of different types of surgery and in some intensive care applications has been shown to halve or more complications. So very, very significant. To bring that bang up to date, back in the end of May, early June, we had the results from a major Spanish government-sponsored multi-centre trial, which has gone on for about 2 or 3 years. Big study, 450 patients. It's the largest one ever using esophageal Doppler, and it's the first randomised controlled trial, rather than other types of trial, first randomised one to be multi-centre. So that ticks a big box in terms of the completeness of the evidence base. But what we found from that is, as you move on to the next slide, 72% reduction in the total number of complications, which is a huge impact on these. Probably more relevant to the individual patient going into surgery, there was a 45% reduction in the number of patients suffering one or more complications. So of these, the 220 odd who had the Doppler, nearly over 1 in 10 of those were pulled out of having complications altogether. So they are not at risk of any complication knocking 7 to 10 years off their life. And then that translates into a length of stay reduction, which is a very broad brush measure of economic cost. It's not the most sophisticated. If you avoid a complication, the hospitals and the health systems avoid all the short and long-term costs of fixing the complication you needn't have had. But length of stay is a pretty good measure for that, and 2 days off that is very significant. So for the sake of whatever it be, 140 euros, I think our probes sell for in Spain. The saving is going to be something in the region of 1,000 to 1,400 euros once you average that out. So very, very significant savings per patient. Splitting that down on the next slide, breaks it down. There's 5 specific complications where they found a statistically significant reduction in that complication as a standalone problem. To highlight those, acute kidney injury, the cardiopulmonary ones, pneumonia, superficial and deep site infection. The superficial is at the wound where the skin gets cut. The deep one is right in there where they're doing the stitching. So if you're having bowel surgery, right in there in the bowel is where that other sort of wound is. Now particularly the acute kidney injury, the AKI and the surgical site infections are important for us because they move into common areas for the patient's safety agenda. And to date we've always been pushing towards quality improvement. Wouldn't it be nice if you used this and patients did a bit better and you saved a bit of money? As you move into the safety agenda, which is a classic thing for a more mature technology to start to do, you're starting to ask much more the questions of when is it acceptable to not use this technology and expose patients to the risk of these things. And given that AKI and the surgical site infections are already quite high up the agendas, I think that's something we're going to push quite hard in the next 2 or 3 years. In terms of the first half highlights, consumable revenues, and for us we generate revenue and high margin every time a doctor puts our probe down a patient. So that consumable bit is really the measure of uptake. So flat consumable revenues as a headline isn't fantastic. Underlying that, what we see is the export markets are going very well indeed. The UK markets having a very difficult time. So in the US, probe revenues were up nearly 40%, 0.8 million. And to put that in context, if we go back 4 years, they were running flat in the States, then they went up to 10% growth, 20, 25, 30, and now we're up to 40. Underlying growth is over 50%. We had a major account that was a bit of a drag by that. And by the time we got to the end of August, we were running at that 50% growth and a bit better once you take some of the currency benefit. Platform program. We're trying to build a platform of important hospitals across the United States who are using our technology and adopting it at reasonable degree, so starting to make it a standard of care. Our goal for each of those, the definition of them, is almost always that they are capable of and on a program to get to 100 probes a month. Now that might take 2 or 3 years to get them to once you get started, but that is the concept. And at 100 probes a month on the back of an envelope means we make about $250,000 a year of revenue at a margin of about 90%, less any support costs that we have. So very attractive business if we can do that. The goal is 30. As of when we put these results out, we're at 27. We've got plenty more hospitals which could get to that stage, qualify we're already active in, and we've got a pipeline coming through. So we're very confident we'll get that and move through that relatively shortly. Internationally, mostly we work through distributors other than in Spain and Canada. Some of these markets are quite established. France, as you know, we've been in there for nearly 20 years. That continues to grow around about the 20-25% mark. I think revenues are up 19% in the first half. Other well-established places all growing: Sweden, Peru, Korea. Korea's not doing very much for a long time now, really starting to show some signs of ramping up. And at the same time as working with the more established markets, we're always trying to open up new territories. These can take a long time. It can take 2 to 5 to 6 years to really get any form of traction going in a new market. I've highlighted 2 there. Turkey, we've had some sales in the first half of 2015, so what's now 18 months ago. Done some good work with the distributor, got some opinion leaders on board. We've got agreement in principle to put in place reimbursement, which means hospitals will be funded by the government every time they use one of our probes. All that needs is a civil servant to sign off on it, and for those who follow the news from Turkey, that may or may not happen imminently. With coups and things like that, you put some risk in. But in past experience, once a decision in principle has been made, it always happened, even if you do get changes in government or coups or whatever happens in there. Thailand, also interesting. We've been working there for a bit and beginning to get some signs of traction. In these places, they're always a bit high risk in terms of forecasting what's going to happen and when, but you keep on adding these in, and every once in a while a new Korea, Peru, Sweden or France comes out of the mix. The UK, not so good. Probe revenues down 36% in the first half. What have we done about that? Sales strategy, we've reviewed it, we've refocused in there. We're really focusing in now on very old-fashioned approach to medical technologies, doctor by doctor, patient by patient, procedure by procedure, and just bed it in and grow like that. That is a real shame. If you look back in history, Deltex is the first medical technology business ever to persuade the world's largest healthcare provider, the NHS, to adopt its new product fully at pace and scale. So that was a full public commitment back at early 2012. Following NICE guidance, National Institute of Health and Care Excellence in the UK, saying this is absolutely as good as we say it is. That's been an absolute fiasco in terms of the implementation. Managed to alienate and switch off the doctors, sent out all sorts of wrong messages, including that people didn't need to do it. So we've gone right back to bases. We're starting to rebuild from that. We had 3 major developments we wanted for this first half. And we're more so on the marketing side, but all very important and all now in place. So new probes, easier to use, stay in focus better, much easier for beginners, very little difference to an expert user. Had those from May, they're going down very well. We had the Spanish trial results I highlighted earlier from June, high impact, but even more high impact once it's published. That could take somewhere between 3 and 15 months, I guess. I would hope nearer the 3. And then we got the first outcome study which looks at the effectiveness of our technology against one of the major competitors in the UK in surgery. And that came out of the hospital, which the other technology came from. So we've gone into the lion's den and come out with an excellent result, as we would expect based on all the science to date and knowing the technologies. In that particular application in surgery, the Doppler did significantly better. Important. Cash-wise, as of 30th of June, we were at £500,000. But I think we announced it before the end of June, and as we went through and got the money in, we raised another $450,000 early in July to top the cash up. July and August highlights, obviously that was June to the half year, 2 months after that. The States growth has continued to increase quite nicely. July and August US probe revenues were 80% ahead of the prior year, and that's at budgeted foreign exchange rate, $1.5 to the pound. So we got a boost in terms of our sterling numbers from the fall in the pound since 23rd of June and the EU referendum. But anyway, more importantly, at that budget rate, those growths in July and August took the year-to-date back up to 50%, despite the drag from this major account. So that's all looking very good. That's a core goal for this year, is to establish growth in the States at 50% or higher and in a way that is sustainable. So the sustainability is there. It's a question of getting over that 50% threshold and then holding it. We've added 3 platform accounts since the 30th of June, including our first paediatric one. I should just highlight paediatric one, that is not a short-term goal to get it to 100 probes a month. It would be lovely if it happened, but we're really starting from the beginning. We've opened up 3 of them. We've not designated one of them, which is the largest children's hospital in the States, as a platform account. We're giving them all the full treatment, and really we've got to work through that and see what really sticks with the clinicians in terms of what you can roll out. So not individual preference, but where there's a strong case to go to the next place and say, really you ought to be using this on this type of patient to do that. The UK trend improved a little bit, so the decline from about 36% at the end of June was back below 30%. It was about 28% year to date by the end of August. So a little bit better. Hopefully that's some of the signs of things starting to work, but we are not optimistic about the UK business in the short term. I think we'll do the right things. The NHS is always, we probably see what's going on 6 months before it hits the headlines. The headlines at the moment are terrible, and it's probably worse than that. So we've just got to work through that and see with that. But I think once we stabilise that starting to happen, that becomes a less of a drag on performance. And we did there in the beginning of the year, we took £100,000 or just over that a month out of our regular cost base before we added in an extra £30,000 per month on additional US staff. So net savings of £70,000, a little bit over that. All of those cost reductions are now flowing through. So we've got to work through notice periods, pay a little bit of redundancy money, all these things like that were done on contracts. So they're all flowing through from September, so that's a big impact on the cash position. And the other thing to highlight now is we've got a new probe manufacturing process. We're bringing things in-house. We're changing the processes to make them more suitable to mass production, but also we think there's going to be a pretty significant cost benefit as we come through that. Our US milestones, when we entered this year, I've highlighted the 5 key milestones we were looking to do. The first one is for the US business as a standalone to become cash generative. And by cash generative, we mean selling enough probes every month to pay the staff costs. And there's a little bit of central overhead. It isn't very much in the States, we're just treating as central overhead. And in fact, we get that at about 1350, 1400 probes, so that's quite a nice buffer. We took a step up in the probe run rate from sort of the 600-700 level to around about 1200 in March. We're running at 11 to 1200, held up well over the summer, which is traditionally quieter. So we've got to see as we come through. We've got a whole raft of new accounts, some of which we've announced, which haven't really kicked into that yet. They're starting in September and October time, as well as a good pipeline coming through. So that goal of 1500 is actually pretty close. So we're looking for the next step up and doing what we can to make sure that step up comes sooner rather than later. The growth at 50% per annum or more, we're on track to do that. That's looking very promising indeed. Our platform program to complete that at 30 accounts. We've got 27 in place. And actually 4 out of our 6 main territories are already past their quota of that. We've had a couple where we've had changes in staff, are a little bit behind, but they should catch up. To see that through, we just got to close out current opportunities. There's no great rocket science in that. National coverage, we've got territories in the northeast, the northwest, the southwest, or the west coast, or down into California, and a couple in the middle. The two main areas we're not covering are Texas and Florida. So we're looking to do that. We're starting our targeting work, starting to get going. Texas is more advanced because we had some historic business in there, and we've got a couple of leads we're working through. Get those up and done. Once we've got all those big population centres covered, we think it makes sense from now on to grow things as they are, grow organically, adding in, recruit people when supported by the cash flows, get started, take it from there. So it's quite a nice, tidy, organic growth model. And at this stage, once we get past that US cash generation, we really do not want to go backwards unless the opportunities change very substantially and there was a real pressing need to do so. The last point is really a marketing one, focusing in on some niches in that. Our core niche is surgery, and surgery is huge. So within that, we're trying to find some specific areas where more than just the evidence and everything like that to do with soft Doppler makes sense. So plastic surgery, we're looking at breast reconstruction, where maintaining the flow optimally is really important to make sure the graft sticks. We're also looking at spine surgery, which is very big in the States, very high risk surgery, and some of the properties of the Doppler make it a really good monitor beyond just the fluid management. So those sort of niches to build within our big niche of surgery. So all very promising. Probe developments, to put some pictures on that. If you look on the left, there's a before and after. The picture, so if you look at the little chart there with the green bit, the way we used to disseminate the ultrasound meant the focal point was very narrow. With the new way we're doing it, it's much wider, which makes it much easier to focus. So it's significantly bigger, and once you multiply those up by pi and everything like that, it becomes that significantly easier, and that's the consistent feedback from pretty much all users, apart from the very best who always found it easy anyway. If you look at the left of the actual image of the probe, you'll see that the crystals have changed. They used to be up-down, so one above the other. We now turn them round to be left-right. What does that do? That really just changes the way that the ultrasound mingles as it comes up, and the waves come in and how they go out. That's what does the bigger thing. It's also part of what we're doing with the production processes. So we're bringing part of that crystal tip assembly in-house. We've started that. We will make some announcements once we've got some hard figures as to what we're going to do with that. That should reduce unit production costs significantly. It means we've got more things to spread our overhead over, and we would expect the margin improvement to start to come through this half. That will come through certainly in the cash side, although by the time the new pros have worked their way through stock, we won't see much of that in the reported margin, and that will come through more in 2017. But of course, when we're trying to get the business cash positive as quickly as possible, getting the cash side sorted first is the priority, and it's looking very, very promising indeed. So final slide is a summary. The US growth rate is rising. It's been rising for the last 4 years and now running above 50% on an underlying basis. We're very close to completing our target of 30 platform accounts, 27 in place as of today, up from 17 at the start of the year. We've got over 25 more potential platforms in the pipeline. I'm out in the Midwest next week, so I'm going to visit 3 of those. Hopefully 2 of them are within the weeks category to push them over and really get started. We've got increased success spreading locally from established accounts. I think it's important. If you look at our news of the announcements of new platform accounts, there's been a trend there towards more of them. You can see where the original platform was built and how we're spreading in that, be that through similar ownership or through local networks. That's very important. I think that starts to prove the model, the ability to grow this organically as we go. In the UK, we've refocused. We've got new developments are in place as planned and on planned. And certainly to me, it's feeling better, but it's not feeling better. I'm not expecting to return to rapid growth anytime soon. But it does feel like it's going to be less destructive to the overall progress going forward. And of course, it's a much smaller part of the business. Manufacturing margin improvement is always important. I think it's always good for a manufacturing company to see the factory actually delivering some of the big changes we're trying to do. That's validated, it's underway, and we'll report more as that goes forward. And we've got the cost reductions we've already made now coming through in full. So I think that ends the presentation.
Great, well thank you very much, Ewan, very thorough. We have a number of questions already, and I would remind the audience that you can submit them by email if you'd like to do so now. So moving on, Ewan, Andrew comments or asks about the US business, looking at the statistics for the platform accounts that you have won and those that are in the pipeline in September compared to July, it does look as if not all accounts actually convert. So could you say a little bit more about what proportion of accounts are converting? Are you comfortable with that conversion rate? And are there any recurrent reasons why those who don't sign up tend to pass on?
There are very few that haven't signed up. If you look at July through to September, and I did look into this, so for instance, we had 3 of those where we had the evaluation in place and everything moving forward were paediatric accounts. In terms of our platform score, not our actual active accounts, but our platform score, we decided it was sensible to only designate 1 of those as a platform account. So 3 account wins, only 1 extra platform. Now they've all got them in, so where are we? We're in big hospitals. The biggest one on the West Coast. We're in the 2 biggest ones in the northeast, or two of the big 3 certainly in the northeast, as well as already having some positions in a couple of the other major ones. So we're already in 5 of the top 10 children's hospitals. So that's why. So 3 wins, 3 new accounts. We've only designated 1 of them as a platform account. As far as I know, I think we've lost 1 where we thought we'd done the evaluation and had everything in order. And of course, these things are never lost forever, because they went with a different technology which frankly isn't fit for purpose in probably 30% of the patients they want to use it. There comes a time just to sit back, carry on in touch, and let people come to their own opinions, and then call us in to try and help with that. So while that's off the short-term pipeline because they've spent their money with somebody else, that is only on a pilot implementation, so it will come back, but that's moved off our pipeline into a sort of pending place for the time being.
Great, and a message of thanks also from Andrew, who is a shareholder, and he just passes on his thanks, which I'm sure goes for other shareholders, that the company does have open offers alongside your placings to give shareholders protection against dilution. Not everybody does that. Moving back to the Spanish trials, which look extremely encouraging, Brian asks, is it too soon in terms of the profile for those trials to say that they have helped the marginal recovery that you have talked about for sales in the UK? And could you comment whether, as a European trial, the results will have resonance in America?
These days, I think all take the last point first, all trials have some form of global resonance. So remember, all the Spanish trial does is deliver exactly what we would have expected. So if you took the nice guidance and their things and it's predicted what you would get from a multi-centre trial in Spain, they've delivered exactly what you'd expect. So it's nice, it brings it up to date, it's confirmatory. You always get not invented here and a little bit of sort of closet racism and snobbery about these sort of things. But it's very hard to argue, and the obvious response to anyone who says that, well, try it on your own patients and see if you think it's going to make a difference, which is effectively what we do through the evaluation and the normal sales pipeline process. So it's pretty high impact. It is the biggest trial ever.
Okay. All right, continuing our global journey. In the UK, Ashraf asks, in the last 3 or 4 years of more difficult trading, do you think you have lost market share to competitor products? And if that is the case, is it easily recoverable?
We've definitely lost market share. If you follow the history through from what the NHS did here, nice guidance, excellent. The NHS clearly needs to look after patients better, although that's never that obvious a priority sometimes, and it would like to save up to £1 billion a year, which is what NICE recommendation extrapolated said that we would be able to do. For some reason which has never been transparent, we never got to the bottom of why they did it, so I think it's a daft decision. When they came to implement this in smoke-filled rooms without the smoking, they came out with a decision there to say, well, you can use either the esophageal Doppler or you can use anything else on the market based on its marketing claims rather than the actual evidence. So effectively giving our evidence base to all our competitors. Now with the Doppler, it's not the simplest technology. You've got to have a pretty sophisticated understanding of the circulation to be able to interpret the images you get. And some people find that quite difficult. Those more sophisticated, so you see in the States, cardiac trained anesthesiologists who are used to using ultrasonic echo devices find our device absolutely simple. It's the simplest, most obvious thing they've ever seen in their lives. People who haven't done that, they find it quite difficult, the learning curve quite steep. So if you go to the things which are sort of plug and play, which give you numbers, most of them based on pressure numbers and some mathematical extrapolation from those, they are easier to use, no doubt about it. So if you think that you're just after a number and do something with that, then that's easier. I think it was a big mistake by the NHS not to properly evaluate the competition. We keep on looking at the evidence. And it's pretty obvious, and it ought to be obvious to the man in the Clapham omnibus, that the Doppler is significantly more effective. So this trial out of St Thomas's is very important. It's not just us saying that, someone's actually gone and looked at it and said, yes, it's better.
Okay, and now the next stop is Europe. Recognising that the UK is a home market, the US is the land of opportunity, could you just dwell a little bit more about which European markets you might hope to make significant headway, and specifically, do you think the Spanish trials will help open up that market in the short term?
The Spanish trial will, in theory, definitely help open up the Spanish market. So it was led, the guy who led the trial is very senior in the Professional Association for Anaesthetists in Spain. We've also been working with a group of the very senior surgeons, so again influential through professional bodies in Spain towards the enhanced recovery bit. And you've now got that group of anaesthetists who believe in the Doppler and the surgeons who believe in enhanced recovery working together. They've got guidelines, they're rolling them out, they've got the support of all the major healthcare systems and the politicians in all the various regions and nationally to make that happen. So in terms of, if we were naive, we would think Spain is absolutely set to fly. I would caveat that Spain, everything takes forever in healthcare, everything takes forever in Spain. Add the two together, things could take an awfully long time. And despite everyone being behind this drive towards enhanced recovery, no one's actually putting any money into it. So you're relying on people to doing it, the doctors to do it out of their own goodwill and their own spare time. And they've still got to find the money to buy the bits of kit, of which we're one of the larger things. So I think it will be slow. I think the opportunity is real. We're tackling it by working with the opinion leaders, with the people trying to drive this nationally, and really trying to focus into a small number of accounts and do it properly. Trying to shift their outcomes so far ahead of the rest that you create a vacuum that sucks the others along behind that. So that's a good program. It's one we developed that having watched what happened in the UK and seeing what you can learn from good and bad. I think that's what we're calling it, disruptive variation. Create the variation. Positive variation is so much better, and that will start to pull the systems through. Sort of thing you do see happening in the States more often, where they have much better data on performance.
Okay, and extending that question in the direction of America, you have 27 platform accounts at the moment, very close to your target of 30. Looking ahead over a reasonable time frame like 5 years, is it a case that you have got a position with the biggest, the opinion leaders that you say, and therefore a material number of further hospitals covered is not required? Or how would you see the market penetration being developed in that time frame?
Well, the next 3 to 5 years, I would hope we would get ourselves into 200 bigger hospitals and start to add on some of the satellites, the smaller ones. One of the ones we announced last week is a very small sister hospital. It's 150 beds of one of our biggest, most successful, newer platform accounts. That's a great, that's going to buy 15, 20 probes a month as we're going well. It's never going to do 100, it might be able to get to 30, but it's all good contribution at the margin. But it's all because we've got the sister hospital and we're in there, it's very low cost to us to support it. Going to that first is very expensive. So I'd have thought 200 of the larger hospitals, and you start to add in the satellites, would be a good goal. Where we're going with our product development, though, is probably more important. What we're trying to do at the moment is establish this esophageal, the Doppler technology, is an important part of the armory for hemodynamic management in modern hospitals in the States. And that's going very well. For our product development, what we're starting to do is add in other technologies and move towards a platform. Conceptually, we're calling it the hemodynamic workstation, where we would offer all the available technologies on a single platform, so you can really the doctors can start to tailor not just the preference, but also what's the most suitable thing to do for each patient. So the esophageal doctor is a brilliant technology, but for someone having a relatively minor surgery who's awake, you don't want one of these things down your nose. There are other technologies which are probably good enough in that low risk situation. We'll start to provide those. Once you do that, I think that strategically will be interesting, because we will suddenly be in a position where we can become the sole provider of hemodynamic monitoring solutions to entire hospitals, which at the moment we're not, and nobody is. Once you can do that, that would change the dynamic in the market, and we'll see where we go from there. And I would hope we would be in a position to really start to try that in about 2019.
Right, and then just a couple of financial questions to finish off with. Firstly, in terms of the new probe manufacturing, which will presumably be good news for your margins, but will you bring all production in-house, or will it be a case of spreading production risk over a number of sources?
Well, at the moment, historically we always had 2 sources. We pulled away from one of those, we're down to 1 source, and then we're building our own capacity to do that in there. Really, it depends where we go with that. It depends what the subcontractor will do with price, frankly. I mean, the potential savings are large, and we would rather bank as many of those as possible financially. So my preference, acknowledging a little bit of risk, having it all in one site, would be to try and put it all in-house if we can, and then you look to a next stage that would start to put in place a second manufacturing facility which would cover the sole geographical location risk.
Right, then lastly, again looking big picture, and your current cash reserves offset against a situation where you are achieving rapid sales growth of probes in America, and you have also been able to implement significant cost savings. Is that cash pile sufficient in your view to proceed with your strategic plan?
The cash pile is sufficient, as is. As I highlighted earlier, we did pick up a little bit of extra capital that was available at the turn of the half year, in the middle of the year, and that was because the UK was performing quite a bit below our plan, and if we didn't have a little bit extra money, we'd have to start looking at putting the brakes on in the States or things like that. So there's a balance in all these things. With small companies trying to turn around there, it is very sensitive, so we've got to keep a very close eye on the assumptions as we go with that. But we don't think, even on the worst case scenarios, that you could see a small gap, but it's a small number now. This isn't particularly big, because we've got pretty good visibility on all the positives, the cost reductions, the US growth, the international growth, to start to really de-risk that, give or take a bit. Longer term, it's very hard to predict where you would go with that. At the moment, we see the growth being able to achieve that organically. It's a high margin business, so once you move into cash positive territory or properly well into that, you do generate an awful lot of cash to fund an awful lot of investment internally. But you'd always, and as a CEO, you'd always want to keep your options open, because you don't know what opportunities are going to present themselves. You don't know what changes there might be in market dynamics or anything like that. But I'd like to healthier position and a much stronger share price.